Hello everyone, my name is Karin Gallandat and I'm going to present results from a pragmatic impact evaluation of water supply infrastructure improvements that we conducted in Uvira, Democratic Republic of the Congo. For this presentation, I'm going to dive straight into the context of our study site, then present the research objectives and results from our qualitative, epidemiological, and economic analysis, and I will end with some key takeaways. Uvira is a town of approximately 280,000 inhabitants located on the shore of Lake Tanganyika in eastern DRC. It has 6 rivers running through the town, and surface water is still one of the main sources for about a third of the population. The use of multiple water sources by households is also widespread, and according to a survey we conducted in September 2021, about a third of the population qualified as water insecure according to the HWISE scale. There is no centralized sanitation system in Uvira, and Uvira is also within a region that is affected by persistent conflict and population movements. In terms of the epidemiological context, Uvira is a cholera hotspot, and we have been monitoring admissions to the main cholera and diarrheal disease treatment facilities since 2009. It is what you see here on this graph. Over 15,000 patients admitted between 2009 and the end of 2021, with sometimes large variations from year to year and depending on the season, but a constant burden. Since April 2016, we have been systematically confirming cholera among patients through rapid diagnostic tests. And this is what you see here on the right. The red color represents confirmed cholera cases, and those represent less than half of admitted patients, which means that other diarrheal diseases are important in this area. And this is consistent with what has been documented in other hotspots. In 2015, or maybe a little bit even earlier, the French Agency for Development and Veolia Foundation initiated a program to improve water supply infrastructure. And this included improvements to key centralized facilities like the water treatment plant and the construction of a new reservoir, which you see here respectively in the middle and on the left in construction. And it also included an extension of the pipe network and rehabilitation of key main pipes. In total, almost 2,400 households were connected to the network, and about 100 new community taps were built as part of the program. And this program provided an opportunity to assess some of the research gaps around the effectiveness of infrastructure improvements to reduce diarrheal diseases, specifically to reduce cholera in a fragile setting. And then we also looked at some economic components. So our main question was about the impact of this program on diarrheal diseases and cholera. And then we combined different methods. So we used qualitative methods like a process evaluation and household surveys to document the intervention and try to look at the changes in the service available to the population as well as household practices. Then we had clinical surveillance, as I explained, to monitor the impact of the intervention on diarrheal diseases and cholera. And finally, there was an economic analysis looking at the cost of illness in the Uvira context. As part of the qualitative evaluation, we identified several challenges, and I would like to highlight just a few here. The main one being extreme flooding events that affected Uvira in 2020, April 2020. That was approximately 6-7 months after the start of the works on the water supply network. 80,000 people, or approximately 3,500 households, were affected, and the main water uptake for the network was destroyed. This had been built in 1958. And with the destruction of the main water uptake, the program team mobilized very fast and was able to install a provisional uptake within 6 weeks. And this allowed to resume the water supply service, but it also drastically limited the production capacity, which had impacts down the line on the quantity of water available to the population. Another challenge I would like to note here is that of electricity supply. Supply through the electricity network has been intermittent, and this has been one of the main causes of intermittency of the water service. And on the graph, you see in the light blue columns the number of days per month where the network provided no electricity to Uvira. And this really calls for multi-sectoral approaches that consider not only water, but also the other sectors like energy and urban planning in the concept, in the design of infrastructure programs. Now, moving on to our qualitative or to the documentation of the water supply service quality over time, we looked at the period between 2017 and 2021. And we saw that accessibility of the taps, accessibility of the infrastructure, either community taps or private taps, drastically increased over the project duration. However, there was this limitation on production capacity, and this means that the quantity of water available per person per day, as estimated based on billing information, actually decreased over the observation period. And for the reasons I also outlined before with the electricity supply issues, continuity also had a rather decreasing trend. So the interruptions in the service were more frequent, and the hours of operation of the pumps tended to decrease over the time that we considered between 2017 and 2021. The affordability is the fourth component of the water service that we were able to look at. And here we have some increased variations after 2020, which were actually not directly linked to the program, but linked to some decisions that were taken at central level related to currency exchange rate. I'm moving on to the epidemiological analysis, and here, with the situation that I just described, with an overall degradation of the water supply service throughout over the duration of the program that we considered, we could not see a clear before and after. So we went for an observational analysis and asked ourselves for a 5-unit increase in quality of the water supply. What is the change in cholera incidence? And we repeated a similar analysis for each component of the water supply service. The overall service quality was measured by an index which we developed for this project. And so you have all of the details here with incidence rate ratios, but I think we can look at this in a slightly simplified form here. And essentially, the main effects that we saw in terms of reduction of cholera incidence were through improvements to water quantity or continuity, and both had a similar magnitude. For 5 additional liters of water per person per day, we would see a reduction of about 24% in cholera incidence. For a 5% percentage point increase in pumping hours, we would have a 25% reduction in cholera. And this is really coherent with previous work that has been published as part of the project. Based on data between 2009 and 2014, there was a very clear association between water supply interruptions and incidence of diarrheal diseases. For the overall service quality, or this index that we developed, we had a 16% reduction in confirmed cholera for a 5 percentage point increase in the index. And this is coherent with the definitions of sustainable development goals, safely managed services. It's important to improve the quality of the service and not only the infrastructure. I'm moving on to the last component of our program. This was about the costs of illness, and we estimated a mean economic cost of $16. This includes direct costs related to transport and medicines, which represent 45% of this amount, and indirect costs related to the loss of productivity by the patient or by their caregiver. And this analysis was based on 175 reported cases of diarrheal diseases during a survey that we conducted in September 2021. Another important information from that survey was about care seeking, showing that most of the cases sought care in pharmacies, which means that our clinical surveillance system likely only captured a fraction of the actual burden of cholera and diarrheal diseases in the community in Uvira. Some takeaways. One specificity of the program was that the French Agency for Development and Veolia involved a research team from the very start, and this allowed to design a system for data collection, eventually resulted in the strengthening of clinical surveillance in a cholera hotspot. We now have this database spanning 12 years or more at this point, and this is quite unique in a cholera hotspot. It has allowed other research projects to piggyback onto the original WASH impact evaluation program. We now have teams looking at CATIs and OCV and environmental aspects of cholera transmission. This program was also a good example of partnerships between NGO, public, private, academia, and implementation partners. And it has been very interdisciplinary in nature. This was necessary to understand and work in a complex environment. We have produced new scientific evidence that can inform cholera control and prevention programs. About 6 publications are already out, and we have a few more in preparation, so stay tuned for more details on this. I would like to end with a big thank you to all the people who contributed to this work at the London School of Hygiene and Tropical Medicine, but also within the Uvira Health Zone. We could really not have collected any data without the dedication of local staff at the cholera treatment facilities. And Oxfam provided assistance throughout the program for the deployment of all the research and implementation activities. And we received funding from the French Agency for Development and the Veolia Foundation for conducting the research. Thank you very much.